Casey here, going to be doing my PAD assessment on our paediatric over here. So to begin with, we're going to make sure our scene is safe. We've got our correct PPE on, using and utilising the correct safety precautions. Once we get to where we need to be, we're going to be doing an ethane report, telling them where our exact location is, the name of the street, whereabouts in the house we are, how many patients we need, how many patients we have, if we need any backup, and if there's any hazards or anything there that they need to be notified of. So now we're going to back up, we need to go in, we need to give our general impression of our patient over here, whether they're limp, what they look like, just generally what's happening from a long, like a windscreen sort of survey of the patient. So now that we've done that, we're then going to gain consent of mum and dad if we can follow up and do some more testing and some more procedures on the client. So now we've got consent of mum and dad, we're then going to do an AVPU, making sure the alertness, the attentiveness and awakeness of the patient is there. So we're just going to say, hey, squeeze them, see if they're looking at us, seeing if they're making any movements, ask mum and dad if this is normal, if they're usually like this or this is different. So now that we've done that, we're then going to assess if there's any life-threatening injuries which we need to take immediate action towards, like haven't lost any limbs, there's no excess bleeding, and we need to do anything about first. So now that that's cleared, nothing's abnormal to the eyes that we can see that's life-threatening. But then we're doing a 360 of where we are, making sure that we have a good access and egress for our own safety and for the client's safety. And then that is it for our beginning. And now we're going to actually continue with our PAD assessment, which is our assessment triangle there. So we're going to be checking the appearance, the work of breathing, and the circulation. So for this, it's the hands-off approach. We're going to ask mum and dad if they can give us some more answers and see if they can help us with the patient. So we're going to sit here and look at the patient, see if they're consolable, if they cry, seeing if mum and dad can sort of comfort them in any way, looking at their gaze, seeing if they're looking at us and knowing what's going on, or whether they're very out to it and not seeing what's going on. Seeing if they speak, if it's being abnormal, if it's slow, anything that's just different from looking from a distance. Then we're looking at their work of breathing, seeing if they're using any accessory muscles, seeing if you can see any collarbones when they try to breathe, like deep like this, seeing if there's any nose flares when they're trying to breathe, which means they've got some difficulties in their breathing. Seeing if they're making any abnormal sounds like gagging or gasping or any sort of weird coughing noises perhaps. Asking mum and dad if this is normal, if they're usually like this as well. And then our last one is circulation, seeing if they're blue around the lips, if their eyes like there, seeing if it's different colours, just noting anything different, whether they look like they're hot or cold, if they're sweating, anything abnormal, and asking mum and dad if they're usually like this. So that's our hands-off. This is mum and dad holding it, our hands-off PAD assessment on the patient. So now we're going to determine if there's any critical interventions that we need to do now, and if we need to take the patient straight to hospital, whether we can continue on doing the rest of our survey at home, or we can do it on the road to the hospital. So after that, we're going to be doing our airway, assessing whether they need any suction, if they need any OPAs or NPAs to try and help with their breathing. So now that that's assessed, we can see that they are sort of having difficulties, but nothing we can do at the moment to help. Then we're going to look at their breathing. I'm going to get my partner here to test, do the rates of their breathing and do their circulation, see if we can notice anything different in their CO2 levels, while I do 4 auscultations of their chest. So we're going to do that, gain consent, listen to the chests on the 4 sides, and then 4 sides on the back. Breathing in and out, that it's equal on both sides, making sure there's no pain, no difficulty on the patient. Then we're going to move on to circulation. We're going to make sure that the capillary feels fine, feeling the temperature of the patient as well when we're doing that, seeing that they're sweaty, anything abnormal there. We're going to do disability, checking the pupils. We're going to put our torches in their eyes, make sure they're dilating, make sure they're following our light on both sides. That's when we're also been doing the Glasgow scale, and then at that point we can radio back into our office and let them know what's going on. At that point, we're also doing our E for exposure, making sure nothing in the environment's making them unwell. Then we're moving on. So once we've done that, that's our ABC, our primary surveys. We're also then going to be moving on and doing our vital signs. While I do a sample OPQRST with mum and dad, my partner's going to do taking all the vitals, making sure we've got all the signs there, monitoring if anything goes up or down. While we do that, then we're going to just weigh up the options, whether we do take the client to hospital, whether we don't, whether it's abnormal, if it's something we can do at home and leave them at home. Usually with paediatrics, I suppose, if there is something abnormal, they're more inclined to take them to hospital. Better be safe than sorry. Mum and dad are usually more than happy to do things like that. And at that point, that's our paediatric assessment done.